Good evening, Dr. Ganesh. You're muted.
Sorry. Good
There you
evening.
go.
How
That's
are
better.
you?
Good evening. Very well, thank you. How are you?
All good, all good. It's been a long day for you?
Yeah, it's still continuing. And you?
Yeah. I mean, I had a break in between.
Okay,
So
okay,
so about, I had 3 hours to relax. Unlike you, I
okay,
think you're
okay.
just
Yeah,
on
it's
this
just
session
carrying through.
directly.
Yeah.
Yeah. Yeah.
Are you which Aravind are you unit are you based at?
So I'm in the center called Coimbatore.
Okay, okay, okay.
So
I
it's
spent
a little north of Coimbatore, north of Madurai.
of Madurai.
And the opposite of Pondicherry, exact opposite of Pondicherry.
Oh, I see. I see. I
On the,
spent
it's on
a couple
the,
of sorry, yes, sorry.
it's on the west coast.
On the West Coast. Okay, okay. I spent a few days at the Chennai unit visiting Dr. Haripriya. Um, so that
Okay.
was, yeah, that was really very insightful, insightful visit and very hospitable visit as well. I have such fond memories of
Oh,
India. Yeah, I've been back a few times. Anytime I get invited, I take up the opportunity. So I've got a few colleagues that we formed a nice community, and I really enjoy
okay.
my time there. Yes, yes.
Oh, that's great. That's great. Nice to hear that. Maybe
Mm.
next time you could drop into Coimbatore as well.
Definitely, I'd be very happy to. I think it would be a great on an opportunity to see. It's just fascinating how, yeah, just how the system, how you've kind of worked the system well, from eye care perspective. Yeah, we've got a lot to learn from that, I think.
Thank you. Thank you. I think, shall I share my screen? I just want to know if it's working fine.
Maybe do that, yeah. So I
Just
can also
wait.
share mine as well. I thought would I think go ahead and see so that I'll be able to say, and then you can let me know as well if mine works fine.
Good evening, Dr.
Good
Samba
Hello,
evening.
good
here.
evening.
Good
So happy
evening.
to have you.
It's a pleasure for us to be here. I could see your presentation, Dr. Ganesh.
Okay. Yeah, you could see that? Yeah.
I did, yeah. Yeah.
Okay. Okay, fine.
I'm going to try and share mine
Uh,
as well. Then
yeah, I'll just stop sharing mine.
Okay.
There are no videos here, so I'll just stop sharing mine. Yeah, okay.
Let me try and see. Share. Mine is not. Yes. Looks like mine is frozen. My screen is frozen.
I think you just have to wait for it to.
Oh, to load maybe. Because it looks like it's on my
Yeah,
end.
it says that
Did it
it
take time
started
for you as
screen
well?
sharing.
Oh, I'm
Not
also frozen.
exactly.
Yeah. I think we're also, if I'm seeing the photo, are you frozen? You and I are both frozen on the video on my side.
Not okay. No, I'm good.
Dr.
Can you hear
Mati, I
me
think it
speak?
could be your internet.
It might be.
If we're frozen,
And I've
if
still got
Dr.
sound.
Ganesh is
Yeah.
frozen, because he's not frozen on my end.
Yeah. Are you
Yeah.
able to
So
see my
I think if
screen?
you no, not yet.
No, not yet.
Okay.
So if you
Oh dear. That's strange that you can hear me.
you
I
could
can't. Yeah,
we
everything
can see you move.
is. Oh, you can. You can see me.
Not now. I think it's frozen now. I think you should disconnect and reconnect again.
I'll try. I'm on a desktop, so it shouldn't really. Yeah, I'm surprised that the sound is carrying, but everything is frozen. My screen is frozen. Everything on my screen is frozen. Oh, this is strange. Okay, I'm going to try and see if I can reconnect to the meeting. Can you still hear me?
Yes, we can hear you.
Okay, let me try and see if I can reconnect because my whole desktop is frozen, so I'm not sure what's parting.
Okay.
Hello, Dr. Ganesh. How are you? Happy New Year.
Happy New Year. Good evening.
Good evening and good to see you.
Good to see you too. That's nice to see you back after
Great,
almost
great.
what, 6 months now?
Yeah, that's 1 year.
Oh,
Almost
one
one.
year now. Okay.
Yeah,
Yeah,
great.
we were in the old
Remember,
building.
July.
Yes.
Yeah. No. Actually, more
Yeah.
than that because it was 2024 July. So it's more
Oh,
than that.
okay.
Yeah,
But
great.
you left in 2025, isn't it?
No. 2024 July.
Oh, okay. July. Oh, okay. Time flies. It's two
Yeah,
years now, almost.
indeed. It has been quite a while. Yeah,
Good. How's your work going? Good. I think
great.
you're continuing since the morning. It's been a hectic day for you.
Yes. It has been quite a busy day. Yeah, great.
Yeah. I managed to get some time off, because I stopped working at 6 and then it's 9:30, so I get some
Oh,
time off.
oh, great. You must have been tired.
Yeah, it's okay. I mean, we're used to that now.
Great. I think Dr. Chifuntu is there.
Yes, Dr. Mumbi, I'm here. How are you?
Good evening. How are you?
Dr. Ganesh, don't get confused. Dr. Chifuntu is Dr. Samba, so same person.
Yeah, I think I gathered that as much. Yeah.
Okay. I haven't seen Dr. Mate rejoin. I hope she's still not having internet problem. Good evening, everyone. So we're just waiting for Dr. Mate. She had joined earlier on, but her screen was freezing. So I'm just giving her maybe a few more minutes to see if she can manage to reconnect. Oh, I see her on the call. Dr. Mate, are you okay now?
I am here, but my video are there. I had to gremlins in the system. I'm I'm on my laptop. I think I'm good. Can you hear me?
Yes, Doc, we can hear you.
Okay, wonderful.
Okay,
Wonderful.
do you want to attempt to share your screen
Yes,
so that
please. Yes,
we're sure
please.
we're not going to have the same problem? Okay.
Yes, yes, please. Let me try that. Uh, is that visible? Are you guys able to see?
Yes, yes, we can
Great.
see it now.
Okay, great. Excellent.
Okay, it's 5 minutes past 6 p.m. CST. I think we will go ahead and start our webinar. All our faculty and panelists are in. I'm just checking if our case series presenters are also in. I see Dr. Mumbi is here. I can't see Dr. Musiwa. Dr. Musiwa, are you in? Dr. Chelu is around. Dr. Mwale is in. So I think it's only Dr. Musiwa who I'm unable to see. Okay, I think I see her now. All right, so we'll go right ahead and start. So thank you so much, everyone, for joining today. This is our first webinar for the year, and we are very, very excited to kickstart this year's webinars on glaucoma. And on the panel, we have very, very interesting members of the faculty, and I will introduce them shortly. Okay, are you able to see my screen?
Yes, and then you can just click on the slideshow.
All right. Okay, thank you so much. So I want to introduce the people on the panel for this night's webinar. And number one on the panel is Dr. Ganesh Venkata Raman. He's the Chief of Glaucoma Services at Aravind Eye Hospital, Coimbatore, India. He is a fellowship-trained glaucoma specialist and has extensive experience in managing complex glaucoma cases, SLT, patchless GDD implantation, canaloplasty, NPDS, GATT, and angular MIGS, apart from trabeculectomy. I may not know some of these abbreviations, but I think Dr. Ganesh will help us as he comes. He's the principal investigator for numerous drug trials for US FDA and DGCI approval at his center. He has 54 publications in peer-reviewed journals and has contributed to chapters in textbooks. At his center, he oversees the fellowship program. He received the World Glaucoma Congress 2023 Young Ophthalmologist Travel Grant Award, and he had the Best of Show Video Award in American Academy of Ophthalmology, Chicago 2024 for his video on canaloplasty. In 2026, ARVO Denver, Colorado, he will receive the Early Career Clinician Scientist Travel Grant Award. Congratulations, Dr. Ganesh. He has a patent pending for iNova pupil expansion ring developed by Aerolab. He is a member of scientific societies like the AAO, AIOS, IPGS, TNOA, and Glaucoma Society of India, where he regularly participates in the scientific deliberations. He was the South Zone Glaucoma India Education Program Coordinator between 2016 to 2018, and he conducted 10 CME programs in Tier 2 and 3 cities for the benefit of general ophthalmologists to enhance their knowledge of glaucoma. He performed live cataract and glaucoma live surgery in TNOA conference in 2014 and 2018, and AEH Coimbatore Sangli Ophthalmic Association in 2023. He was the secretary of the Coimbatore Society of Ophthalmic Surgeons for the year 2019 and to 2020. At present, he is the chair of the Medical Records Committee of the Aravind Eye Hospital in India. Welcome, Dr. Ganesh.
Thank you. Thank you, madam.
Our next member of the panel is Dr. Nombuso Mate. She's an ophthalmologist, a bioethicist, and the current academic HOD of ophthalmology at University of KwaZulu-Natal in Durban, South Africa. She is an adult and pediatric glaucoma specialist trained at Moorfields Eye Hospital in London. She is the vice president of the South African Glaucoma Society and also the president of Women in Ophthalmology South Africa. She's a visiting professor at Wenzhou Medical University and Eye Hospital in Wenzhou, China. Dr. Mate serves on a number of provincial and national committees, as well as the Global Advisory Council for Women Leaders in Eye Health, and is volunteer faculty for Orbis International. Her passions and research interests are in clinical governance in eye care, surgical training, and the management of pediatric and adult glaucoma patients. You are welcome, Dr. Mate. It's so good to have you here. Our next panelist is Dr. Rebecca Nandasaba. She's a consultant ophthalmologist and glaucoma specialist. She's currently based at Kenyatta National Hospital, which is the main referral hospital in Kenya. She obtained her MBCHP and Master of Ophthalmology at University of Nairobi. And she got her ICO World Glaucoma Association Fellowship in 2022 at the University of Yamanashi in Kofu, Japan. And in 2021, she did a course offered by Harvard University in medical writing for the public. You are welcome, Dr. Nandasaba. It's good to have you on the call. And Dr. Nandasaba is here. Okay, thank you. And then we have our very own Dr. Phyllis Mwanga. She's a consultant ophthalmologist and glaucoma specialist at the University Teaching Hospital. She's also a national eye coordinator, and she's passionate about farming, and she's a lover of plants. When you meet Dr. Mwanga, you will know she loves plants because every photo she will show you is a photo of plants. You're welcome, Dr. Mwanga. It's so good to have you on the call. I would now go ahead and allow the faculty teaching session to start. We'll start with Dr. Mate, who will teach us for 15 minutes, followed by Dr. Nanda Saba for 15 minutes, and Dr. Ganesh for 15 minutes. And thereafter, we'll proceed to have the rapid case presentations. We'll start with Dr. Chelu, Dr. Musiwa, Dr. Mumbi, and Dr. Mwale. And then after that, the faculty will come back to just give their feedbacks on the presentations that will be done, and the discussion can start from there. Thank you so much. I hand over to Dr. Mate.
Thank you so much for this invitation by the Zambian Ophthalmology Society. It really is an honor to be with you all this evening. I'm going to be talking about a topic that's really dense, so I've really tried to simplify it as much as possible so that you can take some practical points out of it. And thank you for the kind introduction. So, I'm hoping that this evening my talk will help clarify some of the differences between event-based and trend-based analysis, as well as understanding the mechanisms of both of these modalities. I also hope that you will gain understanding in how these modalities apply to the different assessments that we do, and also to help you develop a decision-making framework when you're assessing for progression. I have no financial disclosures related to this topic. So just starting with some base statistics, only 8 to 16% of eyes show progression on both OCT and visual fields simultaneously. And around 84 to 92% of patients will progress on one modality. So the level of agreement between these two has been thought to be fair, if anything, and at around 0.26 kappa. What this basically means is that visual fields, 17% of patients with structural progression will be missed. And with OCT, if you did OCT alone, around 7% of patients with functional progression will be missed. Visual field is still deemed a gold standard by some for as a gold standard for progression. And some of the reasons behind this is that it is a measure of functional loss. And really, this is what matters to the patient. And this is also how we confirm that active damage of glaucoma. Visual fields also don't have a floor effect, unlike OCT. So one can assess and monitor or appreciate the decline in patients' visual function over time. And where OCT would hit a floor effect. And of course, especially with advanced glaucoma, your visual field might be a slightly better tool to help you monitor for progression. Visual fields also reflect and the direct impact that visual function has on the quality of life. And many trials and studies really use visual field as an endpoint in terms of their assessment. Visual fields also present us with a large global data pool for comparisons, which is important as well in progression. And then in terms of reliability, there'll always be a question around reliability. But when looking at progression monitoring, this we address through, it becomes more repeatable. So the built-in mechanisms within the modalities of event and trend analysis help ensure this repeatability and help us be able to ascertain that the patient is progressing. And then, of course, visual fields present us with universal nomenclature. So no matter where you are in the world, if someone talks about minus 12 decibels, everyone knows what you're talking about. Determining visual field progression in itself can be quite a challenging task and sometimes even harder than identifying abnormal visual fields. And the reason for that is that test-retest variability, which creates plenty of noise. And as you will appreciate in the graph on the left, that area of test-retest variability is that grayed out area. What you'll also see is that with a progressive decline in vision, that window of test-retest variability increases, which means there's increased fluctuations. The perfect scenario is that every single patient could do a perfect visual field, and we would have these perfect points that would be plotted directly and straight on that diagonal line. But unfortunately, that's not really the case. And so as visual field defects deepen, so do fluctuations increase. Similarly, with advanced disease, we get more fluctuations. And of course, those patient factors of fatigue and loss of attention, pupil size, response rates, etc., will impact our visual field assessments. So how does event-based analysis help solve our challenge? Well, in two ways. The first being statistical thresholds. So within these modalities, the statistical thresholds ensure that a change must exceed that width of the gray zone by at least a 95% confidence interval. And a real change should appear greater than the expected variability. The second method is with repeatability, which means the same points must be worse on multiple consecutive tests. Noise will not repeat, but true progression will repeat. Also, event analysis is highly sensitive and can help us sometimes catch changes earlier. And what is the value of trend analysis? Well, it helps us understand how fast the movement is down this graph, and also helps us categorize our patient into a slow or fast progressor. On the other side of trend analysis is that it requires more data from multiple tests for it to be able to develop a reliable slope that we can use. Fundamentally, there are two questions that our progression analyses ask. Very different questions. Event analyses asks us, has something changed from the from the test I've done today compared to the previous test or the base test that I have? Trend analysis, on the other hand, asks how fast is this changing for the patient? There are I'll say four, but it's actually 6 parameters within the assessment of event analysis and trend analysis that we need to look at that help us be able to confidently say that a patient is progressing. So within the visual field, there's event analysis and trend analysis. The event analysis is guided by the guided progression analysis that is built into the Humphreys visual field, and other test machines have got similar products as well. With regards to the trend analysis, we use the visual field index slope. And then within OCT, this is where the extra 2 come in. The OCT event analysis analyzes the OCT GPA, looking at both the retinal nerve fiber layer and the ganglion cell complex, as well as the trend analysis building up a slope for the 2. We dive into the event-based analysis, specifically looking at visual field. Now, this emanates from the early manifest glaucoma trial, which looked at glaucoma patients from varying degrees, mild to severe disease. They did about 12 visual fields test each over a period of 4 weeks to generate this some data that would help develop this algorithm. And there's 4 steps within this modality. Essentially, it needs a baseline of 2 reliable visual fields, and they can be done 1 week apart, which are then averaged to create a patient's normative or reference range. So we use the patient's data. It relies on a comparison model that uses the pattern deviation values instead of a mean deviation. And that helps with eliminating that generalized depression and really extrapolating the focal loss. And then the statistical thresholds really help to account for that test-retest variability that we see with visual fields, and of course repeatability, which requires that every point is repeatedly meets statistical thresholds. event-based analysis helps us categorize the patient into a possible progression or likely progression. And the way that it does that is it requires 3 points from that 24-2 visual fields to be significantly different to the baseline on 2 consecutive visits. Similar criteria help us to categorize as a likely progression. The difference is that it would have to be 3 consecutive visits. What does this mean practically? I'll draw your attention to the visual fields on the right, the GPA analysis on the right, and the red block is really where your analysis and how you read your analysis is. So that triangle indicates the sensitivity at that particular location, which was significantly reduced from baseline. An open triangle identifies the degree of deterioration expected less than 5%. A half-filled triangle indicates the significant deterioration at that very point on 2 consecutive tests. So that same point shows up at the second consecutive test, that triangle is half-filled. And a solid triangle would indicate a significant deterioration at that same point on the 3rd consecutive test. What this means for a half-filled triangle, this is where we are brought to attention in terms of there is something that is happening, and perhaps it might need us to either consider monitoring the patient a little bit more closely, or perhaps, depending on your patient's risk profile, consider augmenting or escalating their treatment. And certainly a solid triangle would indicate that that patient needs to be considered for escalation of medication. When looking at the trend-based analysis, we use the visual field index, and essentially this is a measure that utilizes one single percentage as a representation of the patient's entire visual function. So what it means is, if the visual function is 100% is normal, the visual field index will be 100%. If the patient has no vision at all and they're blind, the visual field index would be 0%. So a patient who has a visual field index of 85%, it means they've had about a 15% loss in function. The visual field index also accounts for functional loss, which makes it really important because it separates us from anatomical loss. And there's 4 calculations that it utilizes. Essentially, what it does is it identifies abnormal points that are worse than the 5th percentile using pattern deviation as well. Those abnormal points are then age-corrected, and this really helps to account for that age-related decline in sensitivity. And then these points are weighted. So the central points are weighted more heavily compared to the mid-peripheral, compared to the far peripheral. And the result of that is the visual field index percentage, which is a weighted mean of age-corrected importance, weighted abnormal points. What does this mean practically? So I draw your attention again to the visual field index slope that we have at the top. What the visual field index requires is 5 reliable tests over a period of 2 to 3 years to generate a reliable regression line. These points are centrally weighted. And caution with this is, if a patient has got change that is more intense in the periphery, your visual field index might miss that because of that central weighting. Your visual field index is then plotted against age and not time, and this really helps with separating glaucoma from age-related decline. And what that slope provides is an indication of loss. So a slope of minus 1.2% per year would equal to 1.2% loss of the remaining function in a year. And so it is normal eyes, in terms of aging eyes, would have a loss of about minus 0.1% to minus 0.3%. And a patient who we would consider a fast progressor would have a loss over 2% per year, which would indicate the need for urgent intervention or scaling up of treatment. Just remembering that those values need to be statistically significant. When looking at the OCT event-based analysis, or GPA, it's really similarly in terms of concept to the visual field. And what is measured here or assessed here is the retinal nerve fiber layer. Reproducibility with the OCT is much better than the visual field, and really because there is less variability, and our OCT, as we know, is a more objective test. This modality is available in the Cirrus as well as other models of OCT, though it may be just a different comes in different forms. And what this modality requires is 2 baseline OCT scans, which effectively can be done on the same day. And then it maps out the retinal nerve fiber layer thickness from the thickness map, uses the deviation map, and then 2 summary parameters. And what it produces is yellow and red pixels. So what does this mean clinically? Those yellow pixels indicate a change that is outside of normal variability. So, and this would have to be present at 2 consecutive scans, and then we would deem the patient a possible progressor. When we have a red pixel, that change must be sustained in that same area for 3 consecutive visits, and we would deem that patient a progressor. What's important as well is that with this strategy, we can actually see where the progression happens. In terms of the trend-based analysis, we get a plot of your retinal nerve fiber layer thickness as well as sectoral, the superior and inferior retinal thickness. And this presents us a slope that gives us information of micrometers of loss per year, where normal loss would be expected to be about minus 0.3 to 0.6 micrometers per year. And you can see how it would vary between a primary open-angle glaucoma and pseudoexfoliation glaucoma, where that loss is quite escalated, almost twice what it is for POAG. And again, these values need to be statistically significant. I touch on macular assessment quickly in terms of the event and trend analysis, because this is really a critical measure as well, really because 50% of the retinal ganglion cells reside in the macula. And your 24-2 visual field GPA will miss about 60% of those patients that are macular progressors. Your ganglion cell complex contains cell bodies and dendrites, whereas your retinal nerve fiber layer is the axons. And so that drives the importance of using these measures. With regards to the event analysis, it color codes your ganglion cell complex deviation map, where green would indicate normal and is above the 5th percentile, and red would then be abnormal and representing a measure of less than the 1st percentile, where the trend is just a plot of that ganglion cell complex thickness, and it's plotted over time, providing a measure of micrometers per year. And we can assess normal as being a loss of about minus 0.14 to minus 0.31 micrometers a year. Again, you can appreciate how primary open angle glaucoma patients will lose ganglion cell over a year compared to pseudoexfoliations. Essentially, anything over minus 1 micrometer per year likely warrants treatment escalation. And remembering this is central, and this would really speak to patient function. So I'm going to use a scenario to kind of drive the key principles. You have a patient who you establish a positive visual field, GPA, showing a possible progression. So what do? Do I do something? You then look at your visual field index slope, and it perhaps falls within normal range of minus 0.3% per year. You then look at your OCT trend, and that looks about normal as well. So what is happening here? Your event analysis might have picked up on focal test-retest variability that might have met the GPA criteria, and that overall rate remains unchanged and it's not clinically significant. So what do? You may not need to escalate treatment for this patient at all. However, you can't ignore the warning of that GPA, and you might elect then to follow up your patient on a 3-monthly basis for the next year to ensure that that trend stays slow. So remembering that the event analysis raises the alarm and our trend analysis kind of guides us into what to do. Just a note and a caveat for patients that might have pre-perimetric change, that this picture might change a little bit because you might not see any change in your visual field GPA or visual field index, but see changes in your OCT, and you need to adapt your strategy or management strategy accordingly. So in closing up, the key takeaway, your event analysis is your smoke alarm system, whereas your trend analysis is your speedometer. If you can ask these 5 questions of your patient at each visit: did any event trigger? Is there a change in my GPA, my pixels, the sectors? Are there trends, looking at the slopes and what the p-values are? Does the structure and the function agree? Is there correlation or concordance? Have I checked the macula in terms of the ganglion cell complex and the TEN2? And what's the rate relative to the patient's life expectancy? And if you answer these 5 questions, it will help you make a confident decision in regards to the patient's management. These are some recommendations in terms of approaching how you have a first-time patient, how do you approach requesting tests or planning for their tests. So the suggestion is doing 3 visual fields and 3 OCTs per year for the first 2 years. You're collecting your data. With a minimum of 5 to 6 tests, you're able to build a reliable trend analysis. And this will really help you to detect those fast progressors within that first 3 to 4 years. And what we do in the first 2 years of a patient's life really can determine the next 20 years. And this is just a practical tip of at the intervals at which you could do tests and how you can adjust it after 2 years, depending on the patient's risk, and how you might approach your fast progressors against your slower, more stable patient. And with that, I'd like to thank you for your attention.
Thank you so much for that detailed presentation, Dr. Mateo. Ooh, there's so much to learn and we are learning. Thank you so much for sharing. Dr. Nandasaba, are you ready to share your screen?
Yes, I am. Are you able to see from your side?
Can't see your screen yet.
Okay, let me just try that again.
Dr. Mate, there are all those clapping hands coming for you. I hope you see them.
Thank you. I did.
Are you able to see?
Yes, we can see your screen now.
All right. Okay, so good evening once again. I'm Dr. Rebecca Nandasaba. Thank you so much for the kind introduction and for the opportunity to share on glaucoma in young patients. The question today is medical therapy versus early surgery in young patients. So I'll kick off with a patient that we've been following up for quite some time. First came in the year 2019 when he was 16 years old and presented with raised intraocular pressures in the right eye. Pressures were 38 millimeters of mercury and in the left eye 40. So he was started on medication and on follow-up, the pressures came down, but over the next several months, we noticed that there was progression, especially in the left eye, and this happened to be going on quite fast. So a decision was made to have trabeculectomy done in both eyes, and postoperatively, the intraocular pressures ranged in the high teens. So on follow-up, there was still some degree of progression, and the patient was put back on Combigan and bimatoprost. So for the past 3 years, the patient has been stable on follow-up. We last saw him in December 2025, and intraocular pressures in the right eye were 10, left eye were 12. Cap disc ratio was at 0.7 in the right eye and 0.9 in the left eye, and there was no visual field progression over those 3 years. So young patients tend to be exposed to juvenile open-angle glaucoma, which is a subset of primary open-angle glaucoma. They're also prone to other types of glaucoma. The much younger ones tend to have a primary congenital glaucoma, and also they're also exposed to possibility of having secondary glaucomas, like those that are steroid-induced, uveitic, or trauma-related. So for juvenile open-angle glaucoma, the age that is affected is defined as from the age of 3 years all the way up to 35 years, but some definition use a cutoff of 40 or 4 years for the lower age and 40 for the higher side of the age. Then luckily, mercifully, it's a rare type of glaucoma that is estimated to affect 1 in 50,000 people. We have noticed that in the African race, the prevalence is a bit higher. A study done in Nigeria showed a prevalence of around 3.4%. So it has an autosomal dominant inheritance pattern, and this has been linked to the myostilin gene, which was previously referred to as the trabecular meshwork-induced glucocorticoid response gene, and also the CYP1B1 mutation. Studies have shown that myostilin genes 40 mutations of the myosin gene have been linked to development of both juvenile open-angle glaucoma and primary open-angle glaucoma, with various studies showing a prevalence of 8 to 63% of patients with juvenile open-angle glaucoma having myosin gene mutation. So this it's not exactly fully understood how it happens and how it causes intraocular pressures to go up, but a study done in Kyushu, Japan, showed an abnormally compacted trabecular meshwork with extracellular material accumulation in the trabecular spaces, which now result in intraocular pressure raise. So when it comes to presentation, unfortunately, just like primary open-angle glaucoma, this type of glaucoma is usually asymptomatic. A few patients may experience symptoms like blurry vision, photophobia, or halos around lights, and eye discomfort. It is important to note that intraocular pressures in juvenile open-angle glaucoma tends to be very high, ranging between 40 to 50 millimeters of mercury, which now results in an aggressive type of disease, which tends to progress quite rapidly. Mean age at diagnosis is around the third decade with a slight male preponderance, and myopia has been shown to be a common association. So now the challenge that we face in this age group really is that, first, as we have noticed, it's silent disease, no symptoms in a majority of patients, and then it falls in an age group of patients who are not routinely screened for glaucoma. End result is patients will present at an advanced stage of the disease when they start having noticeable visual field loss, and on examination they're found to have advanced capping. And this really throws a spanner in the works when it comes to managing patients with the juvenile open-angle glaucoma. On examination, you notice the raised intraocular pressures with capping. It's important to do gonioscopy to check on the status of the angle, which tends to have a high iris insertion or iris processes. Gonioscopy also helps to make sure that the patient does not have any, is not suffering from a secondary glaucoma, which might now alter the course of treatment. Investigations, as Dr. Matia has touched on, which are critical in these patients, are OCTs and Humphrey visual fields, starting from the baseline and the follow-up to help us speak on progression. Then it's also important to have a fundus photo taken where possible as an additional tool in your basket just to monitor progression for this patient, to really have a visual on them. Now, when it comes to treatment, the main goal is to preserve vision and have these patients have a quality life. So we have the option of medical therapy and surgical intervention. So the question is, do we put them on medical therapy and wait on progression, or should we intervene early surgically? The medications that are in our arsenal in juvenile open-angle glaucoma include the prostaglandin analogs, the beta blockers, and the carbonic anhydrase inhibitors. Point to note, alpha agonists are used with caution because they're not, they should not be used in the full range of patients. Notice that some of our patients are quite young as 4 years, and use of alpha agonists in these patients can cause a significant central nervous system suppression and other side effects like bradycardia, hypotony, and hypothermia. So for this patient, it is best to avoid the alpha agonists. Miotics such as pilocarpine have also been shown to be poorly tolerated, because of the ciliary spasms that they cause and induced myopia. So medical therapy, in as much as it has its role in juvenile open-angle glaucoma, it does face a number of hurdles. So first of all, juvenile open-angle glaucoma tends to be refractory to medical therapy. You may not be able to hit your target intraocular pressures with treatment alone, though up to around 10 to 20% of patients, you may be able to get to a target intraocular pressure, but for a good majority, medical therapy alone may not be enough. These are also patients who have a long lifespan, and the longer they use the medications, the higher the chance of exposing them to side effects of the eye drops. Then we also have suboptimal compliance due to various factors, the children, difficulty instilling them, for the teenagers, for them forgetting or just getting fatigued with the use of medication. So Generally now, medical therapy tends to act as a bridge towards surgical management. So when you come across a patient, the first time you diagnose juvenile open-angle glaucoma, you set him on treatment as you possibly think of intervening surgically early. Then the surgeries that are available to us in managing these patients include the filtration surgeries, such as trabeculectomy. We have the glaucoma drainage devices, angle surgeries, and angle surgeries. So trabeculectomy tends to be the go-to surgery, which works quite well, and it's a skill that most ophthalmologists are well trained in, and it has a 50 to 87% success rate from various studies. It is important to use mitomycin C because these are young patients who heal quite aggressively, and if we do not manage the bleb well, it is likely to fail. The other side of the coin is that mitomycin C also does come with its challenges, side effects. Mostly the patient might experience hypotony with attendant hypotony maculopathy, and also they are exposed to web-related infections. But we have to find a balance between the two. The other challenge with the trabeculectomy is that we all know that sometimes we do not get the perfect web post-op, and we may filtration rates, and we may have to employ tactics such as suture lysis and needling, which may not be very possible in the younger age groups who suffer from this disease. Also, for the children, instilling post-op medication, which is important to keep away infection or also to control healing, is also another challenge. But this is not to say that we do not offer that option to them. Then we have the glaucoma drainage devices, the Ahmed valve, Molteno, and Bavels, including others. Studies have shown a 31 to 97% success rate at 1 year, and they are useful in patients who have had failed blebs or patients who, for one reason or the other, have scarring of the conjunctiva. So it has a number of challenges. There's the risk of developing endothelial decompensation over time as the fluid dynamics move in the eye and reduce the endothelial cell count. Also, because of reduced scleral rigidity, tubes have been noted to migrate and also rotate in young patients, with either coming out of the eye completely or touching the cornea and causing endothelial decompensation. The other big challenge that is faced in areas with low socioeconomic levels is that these valves are not readily available, and when they are priced out of reach for most patients. So this becomes quite a challenge in such setups. Then there's also the option of angle surgery, which include the goniotomy and trabeculotomy, either using the Cahook dual blade or the gonoscopy-assisted transluminal trabeculectomy. Then lastly, for patients with the very advanced disease, then we have the option of cyclodestructive procedures. Now, cycling back to medical therapy, it does not entirely is not entirely thrown out in this subset of patients. It may be needed in actually quite a number of patients, with studies showing that 13 to 50% of patients may require post-op medication in the long term to support a lower target intraocular pressures, just like the patient I have presented at the beginning of this discussion. It's important to note that glaucoma is a serious disease, but if we intervene in a timely manner, we are able to stand a good chance of saving vision. And also for our patients, especially the younger ones, let us also remember to offer psychological support as they live with this disease. Thank you very much. That brings me to the end of my presentation.
Thank you so much, Doc. Very, very, very detailed presentation with so many takeaways. Dr. Ganesh, over to you.
Yes, madam. Okay, thank you. And good evening to everybody on the webinar. And many thanks for Dr. Chifunto for the introduction you've given me. I'm very happy to be here, and thanks to Dr. Willard for arranging and inviting me. I'll be sharing my screen. I hope my screen is visible.
Yes, we can see your screen.
Okay. So this is was intimated to me is be a diagnostic gray zone in glaucoma, and the context has been set uh, by Dr. Mate already. So what we are supposed to use for diagnosing glaucoma, I'll just hide my video panel. Okay. Right. So I'll be covering a few case scenarios which I encountered during my practice of so many years, and I'll share with you how we could go about diagnosing and managing glaucoma a little better. Sorry, I have no financial disclosures to make with respect to this presentation. This is a 69-year-old female
Sorry, Dr.
physician.
Ganesh, so sorry.
Yeah.
Could you please put it in slideshow mode?
Slideshow? Oh, okay, just
Yes.
a second. Yeah. Yeah. Is it there yet?
Not yet.
Not yet. Okay. Not yet?
No, but I've seen you pressing on the right button. I don't know why
Okay,
it's not coming up.
Okay, I think I'm using two screens. Just a second. This is good?
Yes. That's perfect now.
Okay, I'll share it again. Yeah, got it. Yeah. Okay, sorry. I was using two screens, so got confused. Okay, sorry for the interruption. So this is a 69-year-old female physician. She has myopic astigmatism in both eyes, and she's on medical treatment for primary open-angle glaucoma. She's a known hypertensive for the last 5 years on antihypertensive medication, and she gives history of undergoing coronary angioplasty about 5 years ago. So she presented to us somewhere around 2025, and this is her finding. So you find that she's got little normal IOP on medication. She's on medication, and her CCT is the pachymetry is slightly on the lower side. Otherwise, she's doing pretty good. And this is her disc features. So you can see that she's got a inferior notch in the right eye, whereas the left eye doesn't look so bad, except for a little bit of peripapillary atrophy. She's got a good neuroretinal rim on the upper and lower portion. Yeah. So the poles are pretty healthy, but here you find that it's really thinned out. And if you look at the OCT, that's what the OCT shows. It corresponds to the visual, the fundus photograph. And you can see that the right ganglion cell layer, as Dr. Mate has mentioned, you have to look into that as well. And you find that there is a significant loss in the ganglion cell also, whereas the left eye is pretty healthy. And we were very perplexed as to why she was progressing. And subsequent visits, she was noted to have progression of the visual field, whereas the left eye was stable. So if it was a primary open-angle glaucoma, both eyes are likely to progress equally, but that was not happening. So because we were very alarmed, we stepped up the medication. She was already on latanoprost and timolol, and we added brimonidine. and that's a visual field in 2018. So we were perplexed as what was happening and why was things happening in the right eye. So right after the patient continued to progress despite uh, medical therapy, and additional investigations were done to rule out any systemic factors. So she had ambulatory BP monitoring, blood investigation, echo, cardiography, carotid Doppler, and everything was normal. Then when we started revisiting the history, the patient had undergone 2019, she had undergone angioplasty, and she was been following up with us since 2015, and she was not taking her blood pressure medications properly. But unfortunately, she developed a ischemic heart disease and she had to undergo angioplasty. And from that time onwards, she was very regular. But in spite of taking her blood pressure tablets and being very well good control of blood pressure, she developed progression in the right eye. And when we started looking at the history, we started looking at causes for unilateral progression of glaucoma. Then we found out she only sleeps on the right side of her, right lateral decubitus position was the sleeping position. And then we were very perplexed. So we decided to check if that is the intervention. What we did was we asked her to start sleeping on the either on the left side or sleep supine. And ever since after that, if you look at it, she had a angioplasty here 2019. And once we started doing the behavioral modification, progression sort of flattened out. And after that, she has not progressed ever since 2020 to 2025. So her rate of progression, as you would, recollect Dr. Mate's talk, the rapid rate of progression is, in her situation was 3.0, and it dropped down to 0.6 after the behavioral intervention. This is for the right eye. And if you look at the left eye, there was no progression at all, and she was continues to do good with a minimal medication in the left eye. She doesn't have any progression in the left eye. So this is one scenario when we can think of behavioral modification and revisit the history and identify why people are progressing in such situations. We'll go on to the next patient. So this is something which I think is commonly seen both in your continent as well as ours, where you have patients who have severe diabetes. And this gentleman presented to us with a progressive vision loss for the last 2 years in the left eye. By the time he reached us, he had lost vision in the left eye. And he has deteriorating vision in the right eye. So he had a history of progressive diabetic retinopathy, and the left eye had gone in for absolute stage. And he presented with active neovascular glaucoma in the right eye. And the plan was that he had undergone PRP and intravitreal, and he was advised glaucoma drainage device with a vision of right eye 6/60 and left eye no PL. Intraocular pressure was 26 millimeters of mercury in both the eyes. And he had a grade 2 cataract in the right eye with NVI. And he had 360-degree laser marks, but the adequacy of the laser mark was a suspect. And the left eye was absolute stage with optic atrophy. So the plan, we were wondering what to do for this patient. So the dictum goes, you do what you know best in your hands. So we could have put in a glaucoma drainage implant or something, some such device. But the important thing here to remember is that you have to access his retina very quickly to ablate the remaining portion of the hypoxic retina. So and this was his angle, so you could see that angles are totally zipped and closed. So he was a monocular status. He needs retinal ablation for PDR and arrest of neovascular glaucoma progression, and he requires a combined cataract and glaucoma surgery. And the surgery has to be uneventful, and at the same time, it has to have very fast rehabilitation so that with that monocular status, he can see better. So we are more familiar with doing a combined cataract and glaucoma surgery, and that's what we did for him. And we were able to provide a clear media, and the retina surgeon was able to examine him thoroughly within a few days of the surgery and start his treatment, which includes ablating the retina. Now, we could always go back and, argue that GDDs are the best thing to go for such situations, but in my personal opinion, I would always err on doing a trab in many of these eyes compared to a GDD. And sometimes this is what happens if you were to do a GDD. This is a patient whom we similarly did a glaucoma drainage implant with a glaucoma valve, and the tube is just where the blood clots are, and you couldn't see the retina, and they were not able to ablate the retina for about a few uh, weeks till the blood clot sort of resolved. So sometimes it's very important that we plan and keep things very simple so that the patients can be rehabilitated a little faster. This is just an example to show you if simple things works, then you don't have to do anything very complicated. So coming to the OCT, which Dr. Mate has also spoken about, I'll just like to highlight certain points on the OCT. So OCT resolves or analyzes certain features which are inherent in the patient. For example, the spherical error of the patient should not be more than -12. It can be up to 6 decibel diopter sphere. And the axial length, when you were to put the patient on a OCT, the axial length of the patient should be between 22 to 28 millimeters of the axial length. So the idea is that very small eyes and very large eyes, the OCT machine may not be able to analyze. And this size also matters a lot. So a machine will default if the disc size is less than 1.33 or more than 2.50 square millimeters. The OCT machine cannot analyze vertical CD ratios below 0.25 sizes. And the normative database does not include data from age less than 18 years of age. And very few high myopes are included in the database. And highly myopic and highly hyperopic eyes have different RNFL profile. So that is something which we have to understand. This is for the Cirrus, and something similar will apply for any other OCT device in the market. So it's important that we use the operative manual and see, go through it, and then decide what patient should be analyzed using the OCT device and what we have to do without using the OCT device. So this is a 55, another case scenario is a 55-year-old female patient with raised intraocular pressure on treatment. And she was sent to us for investigations, and she had all this done, automated visual field analysis and fundus photography. And if you see here, the right eye is pretty good, but the left eye, you have a scotoma which is marching behind the blind spot. So obviously this is something like a rim scotoma. But what we were not very happy is the nasal depression. You can see the spots here. That was not what we expected. And once we look at the fundus image, you can see that the optic disc is at least slightly smaller than the macula. So if you look at the rough estimate, will be like rule of thumb is that if this is the macula, the optic disc is smaller than that, and that's a small disc. And here again, if you were to look at on the left side, you would see that the optic disc is smaller than the macula. Now, in such a scenario, what had happened is that because that nasal depression was there, we went back and saw the OCT, and we saw a supero-temporal loss in the retinal nerve fiber layer. And the red-free picture of the OCT, which is there in the top corner, was very nicely able to analyze that. So you can see the red-free, and you find a notch here, and then RNFL defect here. So this was something which was, and that's the reason why she had a nasal depression in the visual field. So a small disc, you have to be extremely careful, look at it in very much detail, and don't miss small notches, small defects, focal defects, and retinal nerve fiber there. This is another picture of a patient who has a medium-sized optic disc. So you can look at the macula and the optic disc, they are almost the same size. So this will give you a rough estimate that optic disc and the macula are of the same size. So you won't expect the neuroretinodrome is healthy, there is no peripapillary atrophy, essentially a normal retinal nerve fiber layer, and then you have a normal visual field for this patient. And if you do the OCT again, you find that it's a normal structure of the optic nerve head. And you have a large optic disc, which actually is bigger than the size of the macula. So all the patients in our clinic, they undergo fundus imaging first. And then based on the fundus imaging, then we decide whether the patient needs a OCT a device, a scanning image or not. So this is a large disc with a large cup. Naturally, a large disc will have a large cup, and near you also have a very nice visual field. No scotomas here. So a large optic disc will give you a large. And the OCT for this patient, if you look at the disc size, the disc size is 3.16 to 3.37. So this really cannot be resolved by the machine if you go according to the operative manual. So what happens when you, the other features which you can get in the OCT are the areas of white bands and then dark bands and the white band. So a normal disc will have area which is lighter in color in the poles and darker in the middle near the opposite the macula, near the macula where the peripapi bundle is. And these areas will appear whiter. Whereas if you were to have a patient with glaucoma, and this can be seen in the tilted disc also, the area appears glistening, something like a short silk appearance. And this is where the healthy neuroretinal rim is and healthy RNFL layer is. If you go back, you could always look at this photo and see if you have good number of good white areas and white areas near the poles, and then you have dark areas, you would find that this is essentially a normal nerve fiber layer, and this is normal optic nerve head. So a fundus image will automatically tell you that. And here you find that on the left side, if I use the laser pointer, you find retinal nerve fiber layer defect here and some defect here as well. So you have a light band here, a dark band, and then a dark band continues. So this is actually a retinal nerve fiber layer defect. Unfortunately, the patient also had a central serous retinopathy, because of which he has a nerve fiber layer defect. It could be also due to glaucoma. We are just following him up, but just to show you that you have areas of whitish area and then a darkish area and then a darkish area. So it shows that you have retinal nerve fiber layer in this area. And near enough, you have an inferior RNFL defect. So a large disc does not always mean that the patient has a problem. This is a patient with a very large disc, and you find that he's got a very normal visual fields. And coming to tilted discs, so you have some features which are different, oblique tilted discs, and you will always have some field defect in such eyes. So they have some features. So they have myopia, they have astigmatism, and they'll have some pallor. There'll be tessellation of the adjacent chorioretinal tissue. You'll have situs inversus of the blood vessels. You have beta zone peripapilar. They will be associated with strabismus, visual field defects, posterior staphyloма, and you'll always find that you'll have infranasal pigmentary accumulation, chorioretinal atrophy, and because of which, as shown here, you will have superior visual field defects. So abnormalities are there, and RO has a nice documentation of how to analyze the tilted disc and identify how much torsion is present in the tilted disc. So we could go through that. And you have some situations where you have abnormalities of the optic disc. So here you find that on the right side, you have a huge a chunk of retinal nerve fiber, which is very healthy, whereas the left side looks essentially normal. And if you look at the Tisnet graph, you have the right eye in the superior area shows highly abnormal retinal nerve fiber layer tissue. Now, why is that? Because the patient he's got a Beach-Mister's papilla, which contributes to the the structure which is shown as a nerve fiber layer, and because of that, it's showing as a supranormative value. And you can see that on the OCT. So clinical evaluation is important. Not all the patients need to be on the OCT machine for further analysis. analysis, but it's good to document and maybe use it for teaching purposes. But then, because we are limited in resources, it's very important to use the resources justifiably. And as I mentioned, you have glaucoma, you will have a dark band and the white band and the white band here. So here there's a reversal of that. But because this has happened, you must be very, very careful that not to assume that all dark band and white band and the dark band are glaucoma. For example, here you find that this has happened and this is happening in the left side also to some slight extent. Now, but what you would notice here is the retinal neurofibrillary doesn't extend so extensively towards the poles, and the neuroretinal rim is actually more pale than cupped. So this is something which you should look carefully when you're looking at the fundus photo. This patient actually had a hemianopia like this, and he had a right-sided occipital infarct. So always look at neurological causes as well. So the retinal, the RAPD or the relative pupillary afferent defect, and then your pallor more than cupping, and the visual field defect, which the patient will have, and patient may complain that they have a visual field defect, whereas glaucoma patients will be always having a 6/6 vision. Sometimes they may even be in denial that they have any field loss. So this is important sign along with color vision to tell you that this is a neurological problem rather than a glaucomatous problem. So with this, I'll thank Dr. Mumbi again for providing me this opportunity. It's nice to be part of your team. And thank you, Zambia Ophthalmological Society, for the opportunity given. Thank you.
Thank you so much, Dr. Ganesh. Maybe before we proceed to the rapid case presentations, I'll ask Dr. Chelu to get ready. But there's a question for you in the chat, Dr. Ganesh. It says, for patients whose data is not available in OCT database, age limitation or refractive status, can individual patients' data specific data build up be used for follow-up and progression using patients' own data?
Yes, I think you could do that. You could continue to analyze them serially, and you may have to do that manually. Once the child crosses 18 years of age, and then you would see that you get the back data also. So sometimes in really difficult situations, we do examine the children on using the OCT, but we have to do it manually. You don't get the normative database, but you get objective values in terms of the thinning of the RNFL in different clock hours and different quadrants. So you could use that. Yes, we do that. And in the pediatric population, our team from Tirunelveli, the other center, has published the normative database for pediatric population. So we have some guidance to go by. So because of that, we use the OCT in such situations. I hope that answers your question.
Thank you so much, Dr. Dr. Chelu, can I share your screen, or are you going to be able to share your own screen?
You can share from that side. Thank you.
Okay, Dr. Chelo, over to you.
All right, you can go to the next slide. Dr. Chuntu, we can move. Okay. So our case is of a 13-year-old boy who had been followed up for conjunctivitis, allergic conjunctivitis. And on the third visit, one of our doctors decided to do a fundoscopy just out of curiosity. And we discovered this child had suspicious discs. So we tried to look at the family history. There was no nothing positive to show that this boy had a positive family history of glaucoma. And on medical history, tried to probe. There was no history of use of steroids. And on our examination, the visual acuity was 6/6 in both eyes. The IOP was about 15 in both eyes. Colonoscopy was not done. And pachymetry was 5, 8, and 5, 4 microns, the right and left eye. Go to the next slide. The other examinations where I was basically normal, but the discs appeared large according to our assessment. The CDR was 0.8 and 0.7. The neuroretinal rim looked healthy, and there was no retinal fiber layer defect. Go to the next slide. So that's our optic nerve head view of the OCT. Go to the next one. And that was an OCT. Yeah. The optic discs were large, of course, but we couldn't really see anything indicative of this child having glaucomatous changes. We also decided to do a visual field. You got the next slide. That was a visual field for this child. We couldn't really ascertain whether there was any glaucoma in this child. So from these tests, we had the following questions in mind. Next. So we had the following questions in mind after examining this child. So does this child really have glaucoma or there's no glaucoma? Our second question was, is there a role of visual field test in this age group? Because this child was 13 years, and we thought that 18 and above, that's when these tests are more reliable. So that question was, does the OCT play a role in the diagnosis of glaucoma? And for our patient, what are the next steps, and how do we follow up? So those are the questions we had for our patient, which I think which we thought maybe our panel could help us sort out. Thank you.
Thank you so much, Dr. Chelu. I think I'll allow the faculty to respond to the questions. And as the faculty is responding, if at all you need me to beam the OCT or the visual field, please, you can request me to do so. I'll keep the presentation beaming. Thank you.
I have a question. I might have missed it. The refraction. Was there a refraction that was noted for the child?
While we're seeing the time we saw this child at our center, there was no refraction done, but his vision was 6/6 in both eyes. But maybe it's worth noting that when he was sent to another center for investigations, a refraction was done, and I think sorry I didn't indicate the refractive the power of the lenses was given, but I think it was near to plan. I think -0.25 to -5 somewhere there. That's what it was given. But initially, the time we saw him at our center, we didn't do a refraction. The vision appeared normal for us.
And an axial length?
Unfortunately, we don't have those records.
Okay. Maybe just comments on my side. I think the Childhood Glaucoma Research Network has got published some time ago a classification system that's really helpful when you're looking at the follow-up of pediatric glaucoma. It helps you kind of decide these tricky cases where you're not sure, you're seeing a suspicious disc, and how to approach it in terms of sort of longitudinal follow-up, what things to look at. So like progressing cup-disc ratio, an IOP above 21, if you're appreciating focal thinning on the disc, if they're an axial myope. And I've been caught out once before where a patient's refraction was more on the hyperopic plano side, but they actually had a long eye compensated by a flat cornea. So that you could be dealing with an axial myope that has got a plano or hyperopic refraction. So those are things that I would look at. And then, so some of the more subtle things with children would be with progression, they may develop worsening of a refraction and or increasing axial length if you're not really picking up very raised pressures. So those would be some of the things that I would look at. I think if you follow kind of how the table is set up quite nicely, but in terms of just that is to make a diagnosis, is this glaucoma, is it not, and how to approach your follow-up, and those other indices that you would look at. Certainly, I think if you are able to sit the child on a chair and get an OCT, I would do that, which you've done, and then use that as a measure to kind of just help you follow up. And I think Dr. Ganesh had mentioned, you can use OCT and not abuse. And we also have one of our colleagues published sort of a data for pediatric OCT reference range, to find a reference range. So I think you've got those options between Dr. Ganesh and myself if you needed to in terms of assessing your OCT. I will share I'll find the link and share it with everyone.
Yeah, I agree with Dr. Mate. You could always objectify and analyze the patients. I just wanted to know what was the intraocular pressure when the patient came to you? You have the CCT, which is quite high. I think it's around 560 or 570.
Yeah, so the intraocular pressure was 15 in both eyes.
15, yeah. And do you have the do you have the OCT and the fundus photograph in the same location? Do you do your OCT and fundus location, or do you have to send the patient for OCT somewhere else?
We had to send the patient for all the investigations to another center.
Another center, okay. So I think getting the baseline is good because you have a very good baseline. I would many times patients travel far and wide to reach us. So what I would do is I would clinically examine the disc every time the patient comes in and do endpoints of progression. For example, I would look at the intraocular pressure, I would look at the gonioscopy, and then I would look at the dilated fundus examination and compare what I see with what I have already documented. If I find no changes, then I would just review the patient, and other parameters being so, I would review the patient periodically. That's how I would take it if it's a low resource setting. But if you have access to all the investigations, you could always repeat it once in a year and to just be on the safer side, or once in at least 2 years. You could follow up the patients in that manner. This is a large disc. You find the disc area is about 3.33 and 3.34, and you would invariably get a large cup in such eyes. And the cup volume, if you see, it's more than 1. So it's a huge volume of cup which you can see there. So you could always follow up these patients in that manner.
Maybe just to try to get it clearly again. We're talking about a child who's a patient who's less than 18, and how reliable will the serial OCTs be in following up this child, seeing that the normative data is not present in is not as reliable in people whose age is less than 18?
Good evening, everyone.
Okay.
Okay, Dr. Chelo, good evening, everyone. I'm looking at the house. We have people from Ghana and Botswana. You're welcome, people. This is Dr. Monga. So, Dr. Chelo, since we don't have the normative data for people below 18, it would be good, as the previous speaker have said, use the patient's own data. So you do a visual field and OCT and repeat next time. And you compare themselves to what they had last time. So in this child, it will be observation, as Dr. Ganesha said. After 6 months or 1 year, repeat the investigation. Is there any change? How's the pressure? How's the disc looking clinically? But don't treat. Yeah. Then if there's any change, then you can look at starting to treat. But in the meantime, it's observation, serial investigation to see is there trend-based or event-based progressions. Yeah.
If I may make a quick comment on just the OCT, I'm seeing if you look at that superior quadrant, you've got sort of a bifurcation of your retinal nerve fiber layer, and often that can throw people off a little bit because that middle area between the bifurcation can often pick up as thinning. So if you maybe start to see that, it might not necessarily mean that there's progression. But often when I see these big discs and myopic discs often have that, where they've got that bifurcation of that superior retinal nerve fiber layer, and it'll give you the impression of a thinning in that area, which would be typically sort of a red disease more than true disease. So just an interesting observation. But I see that it's not really highlighting even on the sectoral as a thinning.
Thanks for the clarification.
Okay, thank you so much. If there are no other comments from the faculty, we'll move on to the next presentation by Dr. Musiwa. Dr. Musiwa, you have 5 minutes to do your presentation.
Okay. Good evening, everyone. I hope I get this right. Okay, how do I do this? Okay. Share screen. Okay, sorry, trying to do this. Is it showing?
Yes, it is.
Okay, all right. Good evening, everyone. My name is Manyando Msiwa. I'm an ophthalmologist from UTH Eye Hospital here in Lusaka. We saw a patient on the 15th of December, actually was seen by one of our registrars, a male aged 32 years old, who came in complaining of a painless growth in the left eye with a foreign body sensation. The past ocular history was non-remarkable. The past medical history was essentially non-remarkable, except on the day that he was reviewed, the BP was 169/98 and has never had high BP prior to that. So when the patient was examined, the visual acuity was 612 in the right eye, improving to 6.6 with a pinhole. It was the same on the left eye. The IOP was 20.1 in the right eye and 25.8 in the left eye. So this patient just had tarsal papillae and pingicular and some mild conjunctival injection on the right eye, similar to the left eye, except that there was a pterygium. And then the posterior segment, there was a clear field of view. The pink disc CDR was 0.4 on the right eye, and on the left eye, the CDR was 0.5. So our registrar did not make any comment about what they thought about the other structures, with whether it was capped or anything. They just wrote that it was 0.5. So a diagnosis was made of ocular hypertension to rule out glaucoma because of those especially in the left eye where the IOP was about 25, but also that there's allergic conjunctivitis and also a refractive error because there was an improvement of the visual acuity with a pinhole. So this was a supposition at this time. And then this patient was put on olopatidine, artificial tears, and then was ordered to do a visual field test 24-2, an OCT, and pachymetry as well as refraction. So at the follow-up review, the patient came back, I think it was a month later. The IOP was 26.6 in the right eye and 22.2 in the left eye. Refraction had been done and there were just spheres of minus 0.25 in both eyes, right and the left, which were a refractive status of 6/6. Pachymetry was done, and on the right eye it was 506 micrometers and 494 on the left eye, meaning that when we do the correction with these measurements from the pachymetry, so that IOP would increase to about 29.6 in the right eye and 26.2 in the left eye. So the OCT was done, so the OCT was done. There was no particular, as we can see, it's green everywhere. So no particular thinning was noted. So the isn't rule was followed in both eyes, actually. The vertical CDR was 0.6 on the right and 0.62 on the left. The disc area is 1.99 right eye and 2.04 on the left eye. So then the patient also came with the visual field test. So of note, quite all right, this looks like something that is reliable. But then even that which was seen here just wasn't like something that was convincing, like it could be glaucoma, because this could be an artifact from the rim or anything like that, but not that we concluded that that could be glaucoma. And even in the left eye, similar, that was the finding. So so now the predicament really was that, okay, so there is no thinning on the OCT. The OCT, the visual field test is not coinciding with the OCT, but this patient just has these high pressures that he has. And of course, the discs appear to be normal, within the normal range. So, so is it just ocular hypertension, or are we talking about an early onset of glaucoma? So that was the predicament in this patient. That's what we were thinking about. So we thought that first we do an IOP profile, because of course these were two readings that we had 1 month apart, but we thought of having an IOP profile, see a serial number of IOPs, and then maybe try to repeat the visual field test and the OCT in 6 months. So we didn't start any treatments like any of these Timolol or anti-glaucoma drugs or any drugs to lower the IOP, but the patient is on the same drugs for the allergic conjunctivitis. So now this is why we brought the case here, because this is just one of the patients that we have that is young and is appearing with all these like with in the same line like what I've spoken about. So we thought that maybe when we bring it on this forum, it will be very helpful for us to understand, so that we avoid mismanaging the patients, I can say, where we start the drugs and then they are not really necessary to be commenced. So thank you. So thank you.
We can have the faculty to respond and comment on the presentation.
Yeah, I think Dr. Musiwa, a nice presentation. And congratulations on the masterly inactivity which you are showing in managing this patient. Because the moment you look at the intraocular pressure, people will jump into add medication and treat him. And for the next 70 years of his life, 60 years of his life, he has to be on drops. So I think glaucoma, you could take it day by day. I just wanted to ask you one question. What is the tool which you use to check the intraocular pressure with?
So with this particular patient, I think I had to counter check the IOP myself, because of course the patient comes, when they've come from our triage, they come with the IOP that has been done. But then I also did that on the slit lamp just to confirm the IOP to make sure that we had the right one. So it was like we repeated. Yeah.
Yeah, we didn't get the first part. I think the internet broke. So what device did you use for checking the intraocular pressure?
So for this patient, the time that I saw them, I did an applanation. I did applanation on the slit lamp. Yes.
And that's the reading which you showed. It's 21 in the right eye.
Yes.
And 26 in the left eye. That's the first time. And then it was the 24 and 20, or 27 and 24, or 22 in the right and left eye. It got mixed up. I think the right eye increased and the left eye reduced.
Yes. The right eye was 26, then the left eye was 22.2.
22.2. And both are applanation. Both the readings are applanation. The right eye and left eye, and both the times, the first time as well as the second time, it's applanation.
Yes.
Okay. Yeah. So, of course, we wouldn't, we would look at the CCT very closely, and we would classify the patient at the risk of progression, mild, moderate, severe. So if you have a less pachymetry value, you would place the patient on a higher risk, and somewhere around 510 to 540, you would place him on a moderate risk, and a safer zone would be something beyond 560 microns or 550 microns. So that's how we sort of classify it. And this patient had, I think, average CCT, I think 530 or 540 microns.
506 and
506, yeah.
And 494.
Okay. So it's on the slightly higher risk of progression.
Yes.
So I think, did you do a diurnal variation for him? Were you able to get multiple readings throughout the day? Diurnal phasing of the intraocular pressure, about 2-hourly intraocular pressure or office.
We were not able to do that. But we did tell him to come every alternate day.
Right.
So we are yet to see him. I think we're going to see him next week, because we gave him like 2 weeks, but to come every alternate day for IOP profile. Yes.
Yeah, I think a pressure of 25 and above or 24 and above is on the upper limit of tolerability. You would be having a tendency to reduce the intraocular pressure, looking at his, life expectancy and such. So I think if you find wide fluctuations in the intraocular pressure, it's important that you rule out any other secondary causes of glaucoma, especially trauma and things like that. So that's very important. And whether he is using steroids for his condition without, over-the-counter steroids, that's something which you have to look into it.
Okay.
Yeah.
Okay.
And if it's really open angle glaucoma, the first line I would think of would be, instead of putting him on drops, I would strongly consider selective laser trabeculoplasty. I have some experience in doing it in African eyes for patients who come from Africa. And I find that it works quite well, as much as in Indian eyes. if you were to consider treating him.
Yeah. All right. Okay.
In fact, I'll just add to Dr. Ganesh's comments. I don't remember seeing a documentation of the gonioscopy, and I was curious whether there was gonioscopy. I'd be keen to exclude an open angle for sure. I think that can sometimes, a patient could be an angle closure suspect or primary angle closure with high pressure, etc. That could be missed. And definitely to echo Dr. Ganesh's comment on the steroids, I find some patients, we don't ask wide enough and broad enough in terms of steroid contact. Even beyond just, ocular steroids, steroid creams, inhalers, all of those things. Those can really drive pressures up. And I've heard of scenarios where patients are maybe treating or helping to apply steroid creams on their dependents and absorbing, and that raising intraocular pressure over time. So I think just don't neglect an inquiry, a much deeper inquiry into those sort of things. And I think, that was pretty much, I think Dr. Ganesh covered everything else that I wanted to comment on.
Okay, thank you. Thank you.
So to add on what the faculty has highlighted, I appreciate your cautious approach to and how you approach this patient, and put the patient's vision at risk. And on the other condition that they do not have, as the duration, the CCTs of this patient, a bit on the lower aspect, and then also to draw attention to the fluctuations. Sometimes pressures may not be very high, but significant fluctuations more than 0.6 can actually predispose one to developing glaucoma. So it will be important to keep an eye on that, and phasing would play a big role in it.
Okay. I do have a question though. So what is the best suggestion in terms of our profile, this IOP profile that we are doing? We thought we could have it, he could come at a similar time. So this was our advice, that he could come like on the same, around the same time every alternate day. So I don't know if that's the best, or we tell him to come at various times. One day he comes in the morning, the other day he comes just maybe in the afternoon. I don't know what's the best approach to us getting that.
Yeah, I think the more number of readings you take with respect to the intraocular pressure, the situation is going to become more confusing, because you won't know what to do with the data points which you have collected. So you have to bring a conclusion to this situation. And what Dr. Mate has mentioned first is, of course, every time he comes in, make sure you do a gonioscopy, because I think 15 to 20% of people in Africa do have angle closure. I've seen that, and that's documented as well. And so that is something which we have to rule out immediately, because we cannot, if that was so, then a simple laser is just sufficient to blunt his intraocular pressure fluctuation, and you could come to a conclusion very quickly. So that's something. And revisit the history in terms of steroid use, abuse, using of natural things and all. And the more data points you collect, I would suggest that you collect in terms of objective endpoints of progression, that is the visual fields and the OCT, which is going to be more helpful, because intraocular pressure is, every time to take a reading, I always consider it as plus minus 3. If it's 17, I would think it could have been 20, it could have been 14 as well on that particular day. It just is 17 for me today. So you have a patient with high IOP, and it's important that if that is the reason for him to deteriorate in terms of his visual field, then you have to sort of reduce it as well.
Okay, thank you. Thank you.
And maybe one point around the visual fields. I wouldn't make too big a decision on one field. And I don't know whether you have more than one field. So I think with your variability of fields, you want to have in that interaction at least more than one field to be able to see that those points that you're seeing are actually truly reproducible. You might find that, with learning curve and so on, that changes what you're seeing in that field. So I think that would just be the only other thing I would add.
Okay. All right. Thank you.
Okay, thank you so much, Dr. Msiwa. We are running out of time, and I know it's getting very late for Dr. Ganesh. So I'll quickly ask Dr. Mumbi I'll give you 3 minutes, Dr. Mumbi, to do your presentation, and then I'll end with Dr. Mwale. Maybe you can actually just have the presentations follow each other so that the faculty can then comment on the presentations at the end. Thank you.
Thank you very much for the opportunity. So I'll just quickly run through. In fact, I'll cruise through. Yes, so I had this 77-year-old lady with right eye leukomatous corneal scar and left eye neovascular glaucoma. And she's a non-hypertensive and diabetic patient for 20 years. She came to our place with a history of diminished vision in the left eye for 1 month. Right eye has been blind for more than 10 years and was told where she was being followed up that she had optic atrophy. So this is just quickly the diffraction. So vision 360 that was improving to 618. And then this is the right eye. You can see the scar here. We were unable to appreciate the posterior segment. We didn't proceed. And then the cornea in the left eye was hazy. So we went ahead and did anterior segment OCT with Anterion. You can actually see the angles here are closed. And then this is an IOL. Patient had cataract surgery in 2006, I think. Yes, in the same eye. Yes. And then, so we decided earlier on, sorry, I've jumped the slide, but the patient had this neovascular of the iris. I think you can see them from here. This and all around here. So we decided to immediately give intravitreal injection and did a paracentesis and IV monitor for 30 minutes prior to that. And then this is the IOP that were taken with eye care. The patient had multiple visits before. When the patient presented earlier on, did not have the neovascularization area, but the time that I saw the patient, the previous image that I was showing indicated that. So you notice that for the left eye, that the IOP were quite on the high side, and on the last visit after we had given the injection, it came down 25. So the persons we are picking, I think for the right eye is unreliable because of the scar. We did not try to do with Goldman tonometry. So just 1 day post-op, we noted that all the NBIs had regressed. Yeah, so we had done OCT of that eye. You can see from there that there was a depression of the ganglion cell from area. We had not done a visual field at that particular time. So we went ahead and gave maximum glaucoma medications and with oral cetazolamide, and we wanted to have a retina referral for retina angiography and further follow-up, and also a glaucoma referral for possible drainage device. So the only intervention that we did was just giving intravitreal injection and giving maximum medications for the patients. So I wanted to ask, because I don't have much experience with glaucoma, I'm currently just practicing comprehensive ophthalmology, what would be the best approach for this patient? What works in these patients with NVG? And could you comment on prognosis? How should I counsel this patient? How aggressive should we monitor? If, say, for example, we did filtration surgery, or we gave a glaucoma drainage device, how should we be aggressive in managing the neovascularization? Thank you.
Maybe before Dr. Mumbi stops sharing, I just want to confirm if the faculty took notes of the question.
Yeah, yes, please, yes.
All right. Okay, thank you so much. We'll go ahead and have Dr. Mwale's presentation, and then we'll have faculty to come back and give their remarks. Dr. Mumbi, you can stop sharing your screen.
Oh. I think I stopped. I can't see, sorry, I think I'm lost. Am I still sharing?
Yes, you are.
Dr. Sampa, can you hear me?
I think I'm lost. Am I still sharing?
Yes, you're still sharing, but I think I will share Dr. Mwale's presentation to overshadow yours.
Yes, you can override me.
Dr. Sampa, are you able to hear me?
Yes.
Colleagues, can you hear me?
Yes, we can hear you.
As we conclude, he's sounding very unstable. I hope I'll be able to run through my presentation. Thank you, Zos, for the invitation, and thank you for inviting the panelists who've been able to share comprehensively on glaucoma management and its challenges. I'm Dr. Mwale. I'm a glaucoma specialist, Chief Medical Officer at Kabwe Eye Hospital. We can move on to the first slide. So the first case we are sharing is that of a female medical doctor, aged 25 years, who presented with blurry vision associated with tearing, with a positive family history of glaucoma in the family. The best collected vision was normal, with simple myopia, with intraocular pressures within normal gonioscopy. Pachymetry was not done. The CD ratios were 0.6, 0.7, and appeared more capped in the left compared to the right eye. Next slide. So this was the visual field test done on the 5th of February, and it was essentially normal. Next slide. This was the OCT, which was essentially normal, but to note that the disc size was about 2.5 millimeters in both eyes. Next slide. So although the discs were suspicious, we made a decision that these were just large discs with normal Humphrey visual field report and OCT reports, with also an indication of good inter and intra-eye asymmetry. And we advised close follow-up, no glaucoma treatment, and that we should further do DV intraocular pressure, CCT, and wide view OCT, where we indicate the nerve and the macula. So the patient will be on follow-up every 3 months, and we will determine the course of therapy during a close follow-up. In the case of, in view of time, I don't know if I can be allowed to run through my second case. Okay, good, thank you. The second case is that of a patient who presented with no complaints at all, but just change of spectacle prescription, male, a religious reader. Best corrected visual acuity was normal, with normal intraocular pressure on 2 visits. The DVOP was also normal. The risk factors identified were being on hypertension treatment with a positive family history of glaucoma. Next slide. So when we did the visual fields, the left eye was essentially normal. Next slide. I hope you are able to see superior temporary on the right eye, nerve fiber layer defects with a notch superiorly. Next slide. The defect on the right, you could see the yellow superior temporary on the OCT. Next slide. So we made the diagnosis of mild normotensive glaucoma for both eyes and started the patient on timolol, and we encouraged compliance with hypertension management. The patient was on amlodipine 10 milligrams OD, and we have since commenced a close follow-up so that we can do visual field and OCT progression analysis as was shared in the first presentation. So these are the two cases we thought we could share for this discussion. Thank you.
The panel, over to you.
May I ask you to show us the OCT if you can? I missed that. If it's still possible.
For the first patient or the second one?
For the second one.
Okay, there it is.
So I think oh, there. Okay, this is I was trying to follow with the doctor saying that there was somewhere where he saw a nerve fiber layer defect, and I was showing right. Okay, so it's two separate OCTs.
It was very clear on the fundus photos, the right eye superior temporary. Maybe you could show the fundus photos.
And perhaps one other question, did this patient have a gonioscopy done?
Yes, gonioscopy was done. It was normal findings, open angle with normal iris configuration.
Also, a question for the OCTs. I see there are two sets. How far apart are they taken?
They were done in a single setting. We find it that we get more information if we do the OCT nerve analysis and combine it with another view of OCT nerve with macula. Sometimes what you miss when you just look at the nerve, you get it when you combine the nerve with the macula. Thank you.
Yeah, I'd like to add some points here. Of course, the first patient, I think the gonioscopy was not done in Dr. Phil's presentation. I think that has to be done because she's a medical student and young patients. So people with ladies have a tendency to develop angle closure. So that's something which we have to look into. So once you do the gonioscopy, and that will complete the picture for that patient. And this particular individual, the second patient of Dr. Phil's presentation, the RNFL layer, the OCT, of course, as Dr. Phil mentioned, it's you have a little bit of nerve fiber layer defect, but if you look at the neuroretinal rim, it's pretty healthy, and it is following the isn't rule. So sometimes for other reasons, there are some publications in which people with fluctuating blood pressure have shown retinal nerve fiber layer defects, and patients with iron deficiency anemia have shown retinal nerve fiber layer defects. So that is something which we have to look into. It may not be glaucoma per se. And I think he's about 53 years of age, this particular patient. We could monitor his blood pressure, make sure that it doesn't fluctuate very widely, and also make sure he takes his hypertensive medication in the morning and not in the evening, and monitor him serially. And then see if because glaucoma is such a slowly progressive disease, that nothing's going to happen overnight, and you can take a call if his the ganglion cell parameters remain constant. Then you may not treat him with glaucoma medications at all, and just monitoring will suffice in this particular patient. That's my few points which I wanted to add with regard to the presentation. Of course, we still have to cover Dr. Mumbi's presentation.
I'll make just two quick comments as a follow-up from Dr. Ganesh. I think if you're dealing with a suspect or a normal tension glaucoma patient, I'd also be worried about making sure that their hypertension is monitored, because they are, there's some vascular path aspect of their disease, and you don't want them to drop their blood pressure too much, and you are at risk of having an additive effect in combination of your topical beta blockers and the systemic antihypertensive. So maybe a good idea would be to ask the patient to occlude to their punctum when they instill their timolol, so that you can reduce any systemic absorption. This is now working with a normal tension glaucoma. And the first case, I found that there was a little bit of, so I'm going to jump to the first case. I found that there was a bit of discrepancy in the OCT with the peripapillary retinal nerve fiber layer and the ganglion cell. It just caught my eye that there seemed to be a little bit of discrepancy between the two, the retinal nerve fiber layer and the ganglion cell complex. There was quite a bit of loss in the ganglion cell, but that retinal nerve fiber layer looked normal. I think it was the case before. Where did I make a note? I don't know if it's this. There was another case, but it's fine if we can't get to it, so that we can get to the next case. Yeah, it's okay. We can move on to the next case. Maybe others will want to comment, and maybe the other faculty wants to comment.
For me, for the last patient that we have listened to his presentation, I'll take the more cautious approach and follow up this patient for a bit, and just to establish if there's actually glaucoma or not before committing them to treatment, and also put into consideration centration when we're doing the OCTs, just see if it's capturing the correct mapping out of the retinal nerve fiber layer thickness, or if there's any variability in that.
Maybe we can have some comments on Dr. Mumbi's presentation. Yes.
Yeah, okay. I think the patient needs definitely a GDD. And to be nice, I don't know if he's diabetic. I had stepped out. You do the Avastin, you do the PRP, then you put in a shunt, at least to try to reduce the chance of the NVIs. So I can send the patient over, Dr. Mombi, in the next 2 weeks.
Okay, thank you.
I have a
Yeah,
question for Dr. Dinesh.
No, go ahead, please.
Yes, so I was curious what your I think our practice has kind of been sort of what Dr. Munga has highlighted, neovascular patients and putting in a shunt. And I noted in one of the cases you presented, that you opted for a trabeculectomy, a combined phaco-trab. And I was curious how you approach your post-operative management and bleb management, knowing that these patients are at high risk of failure for multiple problems. Post-phaco, it's a inflamed eye, neovascular, all of these factors. Is there anything that you do differently maybe in terms of your post-operative management? Some pearls that we can get?
Yeah, I mean, we plan for the surgery immediately after the intravitreal injection. So within the window period of 5 days, we would proceed with the procedure. And if the intraocular pressure is very high, then we try to reduce it with intravenous mannitol prior to the surgery. I also practice a little bit of anti-sclerotomy because while doing a procedure about 8 millimeters away from the limbus in the infratemporal quadrant, I would do a prophylactic anti-sclerotomy because these eyes have a tendency for suprachoroidal hemorrhage on table. And a sclerotomy will prevent extravasation of fluid into the vitreous cavity. It will go through the sclerotomy, and that helps out a little bit. And at the same time, we would usually do a phacoemulsification first, not open up the conj or the trab. And then after we close the wound, then we go ahead and do a trab. Now the trab, of course, once we before decompressing the globe, we would do an anti-sclerotomy. And once you have done the trab, it would be fixed tight sutures. Now, in these eyes, we're not trying to reduce the target pressure to 12 and 13 and 14. If you can bring it down to normal physiological levels, that's sufficient. It could be anything less than 20 with or without medication. Now, the trab is usually a sacrificial trab. It's not something which is going to work for very many years. So instead of doing a tube shunt at pressures of 40 and 50, you could do a staged procedure. So you could do a trab, and then about 4 or 5 months or 6 months down the line, you could always come back and do a tube shunt. So it's a staged procedure is what we plan. They will require a long-term procedure in terms of a filtering site away from the angle, which a trab is actually not ideal. So if you take a filtering site using a tube to the equator, that works very well. But this is just to get the retinal people access to the retina so that they can ablate the retina very well. And then you could plan for your procedure. And many of the patients who have this, we counsel them very well in terms of control of hypertension and diabetes and other microvasculopathies, particularly related to hypertension, because we know that autoregulation takes a beating in these eyes. And the diabetes patients, they have a tendency to have carotid occlusive disease as well. And those plaques, they sort of break away and cause ocular ischemic syndrome as well in many of these eyes. So you have fluctuating intraocular pressure with waxing and waning of the neovascularization process, irrespective of the diabetic retinopathy, which the patients have, or the central retinal vein occlusion complications, which many of these patients have. So we address that by strictly controlling the systemic features of the patient. So if they're not on insulin, they have to be on insulin. They have to control their sugars very well. They have to control the hypertension very well. They have to see a cardiologist and endocrinologist every 4 months for any of these procedures to work. So for 10 months, they should make sure that nothing goes awry in terms of systemic control of the systemic factors.
Okay, thank you so much. I'll invite the faculty to just give under a minute a takeaway message to the participants. Anything you want to say, your closing remarks, your last remarks, I will appreciate that. We can start with Dr. Ganesh, since he's already on the floor. And then we go to Dr. Monga, Dr. Nandasaba, and then Dr. Mate. And then I'll invite Dr. Mumbi, our ZOS president, to give the closing remarks, and we'll end the meeting. Thank you.
Thank you for the invitation. And maybe the biggest pearl is for me, I would like to say, is that keep looking at the endpoints of progression in glaucoma. The interpret should be recorded with a standard of care equipment. The visual fields has to be done according to the guidelines set by various our associations and what the literature says. And follow-up should be mandatory. And always try to revisit the history. You may never know what comes out. A patient applying steroids to his own relative, and you could be surprised at the number of times that happens, and we could catch that. And behavioral aspects, like in India, we do the Shirshasana, which is standing upside down. The yoga practitioners do that. So always revisit the history and find out what is happening, why it is happening. And if you do your math, you will always come to a conclusion. Thank you very much.
Thank you so much for our faculty, my colleagues, for the great presentation. Maybe the last thing I want to say is maybe to our colleagues, especially our students, when you have someone with unilateral glaucoma, always ask why, what's going on. And usually most of the time you find the answer right there in the eye. And to always investigate and follow up the patient, and not to treat the patient based on maybe one OCT or a visual field. They should all be used together, including the patient's examination. So thank you so much, everybody.
Okay, thank you. I've enjoyed today's discussion very much, and the different cases that have been presented. My takeaway is to always remember that we look at glaucoma a bit more like a jigsaw puzzle that we need to put together to get the full picture of what is going on. So always when you have a patient, make sure you take a thorough history, do a proper examination, including gonioscopy, which is very, very vital in terms of now knowing exactly what is going on with your patient. And for those patients who tend to be borderline, dig deeper in terms of your history. And if you're not really, really sure, there's always room to follow up the patient and see if they actually have glaucoma or not. And then for those who have neovascular glaucoma and diabetes and hypertension, you find that in quite a number of settings, the pressures are quite high and may tend to give them Diamox. Always take time to check their renal function test so that you don't expose them to Diamox, especially for the high doses, if they have a degree of renal failure, and work in tandem with the other consultants, like the nephrologists, for best care of the patient. So always remember, patient is not an eye, it's the whole body. So put them into consideration in every way.
Thank you to the Zambia Ophthalmological Society for the invitation, and it's been great to be serving on the faculty with my fellow colleagues. I think I've got 3 points, and some of them have sort of been touched on. For me, if you've not looked at the angle, your assessment is incomplete, and I think Dr. Ganesh did touch on it. There's a lot of underestimation of how prevalent angle closure is in the African population, and there's a complete mismatch between your von Herrick assessment and presumed angle closure. So just keep that in mind. I think when it comes to OCT as well, I know a lot of people still focus on the peripapillary retinal nerve fiber layer. If you understand what we are looking at when we're doing OCT, we're really assessing the retinal ganglion cell, and the death of the retinal ganglion cell is like a biomarker for glaucoma. If you're only going to assess the axons and not really look at the cell bodies and the dendrites, you're kind of missing the picture. So I think make a habit of ensuring that you are assessing your ganglion cell complex. I think all of our presenters did that today, but it's still in practice. I still see that many people are still a little slower in really making sure that those two parameters are there. And lastly, I think echoing Dr. Rebecca's comment, we know more around, and there's so much more evidence coming out about the impact of systemic conditions on glaucoma. And a patient is a whole patient with an eye on the patient. And I think Dr. Ganesh also alluded to some conditions around blood pressure, the influence of blood pressure, it's diabetes. We must look into those aspects as well when we're managing our patients to get a fuller understanding. And there's certainly certain conditions where they can affect the risk of progression if we're not aware of those conditions, such as hypertension. With that, thank you.
Thank you very much, everyone. So if you can just allow me to indulge only for the 2 seconds, I just want to promote the contact lens workshop that we'll be having on 1st and 2nd April this year. It's the first time that we'll be having it. So Lusaka Eye Hospital is going to host it. And it's only 2 days. We have great presentations, and you can see some of the presentations that are there. We are hoping we can have more people coming through. And then beginning next year, we'll be having the presentations for 5 days and once a year. So we are inviting everyone from across the neighboring regions and everywhere else. I specifically want to thank each individual faculty for accepting this at short notice because this is just a month ago when we said, could we have this presentation? But we are willing enough, and you gave us great presentations, a lot of learning points. And believe me, from now onwards, about 90 or so 100 people attended this. You have made a difference in their lives and their practice, and you have reached out to maybe 100 times 90 patients. That's a huge number that you have really touched. We have had participants from Ghana. We had a number of them from Ghana. We had participants from Kenya, from Mozambique, Dr. Mundulai, from Botswana, from South Africa, and also from Zimbabwe and Malawi. So it's quite huge. And Dr. Ganesh, you have really reached out further away. And thank you very much from the time I was in Aravind for accepting me, sneaking into your theater, see what you do, into your OPD. And thank you very much, Dr. Mate. I understand you have been here before. We are asking you to be coming back sooner. And Dr. Nandasaba, thank you very much for accepting, and Dr. Monga. So we are going to have this presentation soon uploaded on our YouTube video. For the past 3 years, we don't have much, but I think you see the other presentations. So this, you should not think you have missed out a lot. And then we are creating our website. It will be launching it this month. So you find a lot of interactive things there. And also please follow our Facebook page, and let's continue sharing. Thank you very much, and we are greatly thankful for that. We'll be inviting you again. Hopefully you'll be coming. We'll be hosting COEXA 2027. So hopefully we can have you come along, and this year we'll be having a scientific conference end of the year. Thank you very much, everyone, and for the patience.